This is The Rounds Table. All right, welcome back, listeners. This is going to be a solo episode, and the article is entitled Metformin for Knee Osteoarthritis. That's right, Metformin for Knee Osteoarthritis in Patients Who Are Overweight or Obese, a Randomized Controlled Trial. This was published in JAMA in April of 2025. A quick backdrop. Knee osteoarthritis is incredibly common. Turns out it affects more than 300 million people globally. More than half of these patients who have knee osteoarthritis are obese or overweight, and basic science studies, I didn't know this until I read the study, but basic science studies suggest that there's an element of impaired glucose and lipid metabolism which promotes inflammation and can increase disease progression. I'm very skeptical of that, but hey, apparently there are basic science studies that show it, so I will buy it. We know that metformin is safe, cheap, and it reduces hepatic glucose production, reduces insulin resistance, among other effects. So these authors wondered, could it help with osteoarthritis among individuals who are overweight or obese? And there have been observational studies that have compared metformin to no treatment and showed that metformin improves osteoarthritis, but I just don't buy those studies. Okay, so going back to this clinical trial, how was it designed? It was a double-blind, placebo-controlled trial conducted in Australia from 2021 to 2024. It was primarily a virtual trial. I got to imagine that was partially because of COVID. And what's kind of interesting is that as part of the trial, they taught patients how to examine their knee for crepitus, tenderness, and warmth, among other features. The included population were adults with symptomatic knee osteoarthritis. So some key inclusion were age 40 and up, BMI of 25 and up, knee pain for at least 6 months, and pain more than 40 millimeters on a 100 millimeter visual analog scale. So for those visual analog scales, just imagine there's 0 on one end, there's 100 on the other. Where is your pain? And they also had to have a NEOA based on ACR criteria, American College of Rheumatology. I won't go into those criteria because I don't know what they are. Some of the key exclusion, if they had severe osteoarthritis, if they had severe pain, that was defined as more than 80 millimeters on that visual analog scale ranging from 0 to 100 millimeters, if they had an upcoming knee surgery planned, or if they had diabetes that required medications like, metformin. And then there was other exclusion criteria, but I'll leave it at that. The intervention was metformin extended release up to 2,000 milligrams daily compared to placebo. And the outcome was the change in pain in that visual analog scale at 6 months compared to baseline. And the outcome was assessed by a blinded research assistant. So the results, 225 patients were approached and 107 were randomized. Mean age was 59, 68% were female, typical BMI was 33, 25% had high blood pressure, and I'll just note up front that 80% of patients completed the primary outcome measure at 6 months. That also means that 18% were missing the primary outcome. I also want to talk a little bit about the adherence here. So they determined adherence based on patients returning their medications back to the study team, and then the study team would count pills to see, okay, how many did the patients actually take? This is a common approach for estimating adherence in clinical trials. Very imperfect, but a common approach. And it turns out that, again, only 38% returned their medications to have adherence assessed. That means the other 60% did not, and we have no clue what their adherence was like. So among those who mailed the pills back, they could estimate adherence at 82% with metformin and 79% with placebo. Okay, so for the primary outcome, at 6 months, the mean change in the visual analog pain scale, so a reduction in 31 millimeters in the metformin group and a reduction in 19 millimeters in the placebo group. So a between group difference of minus 11 points, corresponding to an effect size with a standardized mean difference of 0.43. I know that's completely uninterpretable, but don't blame me, I'll blame the authors. I also want to talk about the adverse events. This is unsurprising, but the most common adverse effects were diarrhea at 15% in the metformin group compared to 8% in the placebo group. The metformin group also was more likely to have abdominal discomfort. So, putting this all together, first I'll start with the author's words. So, their opening sentence of the discussion is this. In this community-based randomized placebo-controlled trial, participants with knee osteoarthritis and overweight or obesity, treatment with metformin for 6 months resulted in a modest reduction in knee pain and stiffness and improvement in knee function. I am very skeptical of that, okay? So first off, 20% of patients had a missing primary outcome. So that can potentially undermine the findings because maybe a subset of those patients didn't have a primary outcome because they went on to have like a knee surgery, for example. All right. So that's one really important drawback and limitation of the study. A second limitation of the study is that only 38% mailed their pills back to assess adherence. So we really don't know how good the adherence was overall. And then finally, we know that the group that got metformin was far more likely to have diarrhea. So these patients were unblinded. They probably Googled the fact that, hey, I'm having diarrhea and I'm in this trial of metformin versus placebo. And I'm sure ChatGPT then said, okay, you're probably on metformin. So I just don't really buy that metformin is going to be a good idea for patients who have knee osteoarthritis, full stop. I also think that there have been other trials. The most relevant was a large-scale double-blind trial of semaglutide for adults who had obesity and knee osteoarthritis. And that trial showed a massive effect size. So again, I just don't buy that metformin is going to be the answer in this patient population. I think a final teaching point, and yes, I am teaching now, a final teaching point is just like having a good approach to evaluate the quality of a randomized trial. And one acronym I've come up with is PHOBIA. So the P stands for placebo-controlled. Okay, so this study gets a big point for being placebo-controlled. H stands for how is it funded? This was funded by academia. O stands for the outcome. Is it relevant? And how much missingness is there? So is the outcome relevant? I guess, right? Like I think patients do care about their knee being less painful, but was there a lot of outcome missingness? And the answer is yep. 18% of people had a missing primary outcome. And when the primary outcome is missing more than like 5% of the time, I just get a little worried about how much can we rely on the results of the study. B stands for blinding. On face value, this was a double-blind trial, but not all double-blinded trials truly blind the patients. And when you have an adverse event, which is like so common with the drug in question, aka in this case metformin causing diarrhea, then I think you lose some blinding. I stands for intention to treat. I won't go into details for that. And A stands for a lot of patients, a lot of centers. And this trial didn't have a lot of patients. And when you don't have a lot of patients, your results can be fragile. All right, that is it for this solo episode. Good stuff on my end. Speaking of osteoarthritis, speaking of general medicine, speaking kind of diabetes, I guess, with metformin, just plugging diabetes trial files. This has been a popular trial files that we've started, at least a year ago. And of course, the OG trial files is still going strong, continuing to grow. So sign up for those if you haven't already. All right, that's it. Stay well, and until next time.
The Rounds Table is hosted online at medicinepods.com, your one-stop source for comprehensive internal medicine education and evidence-based medicine resources. We can also be found on all of your favorite streaming services. You can also follow us on Instagram, LinkedIn, and X. And special thanks to our audio editor, Tamara Van Bakel.